Here we will see two cases of vitrectomy with severe corneal opacity. First, we have placed the flaring ring of proper size. On the left video, we have used 23 gauge, whereas on the right, 20 gauge. Determine the size of corneal trephine, preferably a large diameter should be chosen. Trephine the corneal button. Once fluid egresses, this is a signal that the anterior chamber has been penetrated. Considering switching to sharp blade or scissors to complete the incision. Here we have an open sky eye. We are removing an fibrin mass like on the left video and performing anterior vitrectomy on the right. All these manipulations are easier with an open sky eye, but the risk of an expulsive choroidal hemorrhage should always be on the surgeon's mind. Place the keratoprosthesis with the Eckhart or Landers model. Ideally, no leakage during the vitrectomy should occur, although minor leakage is usually acceptable. Now we are penetrating deep into the intravitreal cavity, taking care to reduce the risk of causing an extensive iatrogenic retina injury. Once the retina is identified, we complete the posterior vitrectomy, including detachment and removal of the posterior cortical vitreous. Here we are shaving the vitreous base with low suction and high cutting. Now, as you see, we are picking up the intraocular lens, which has fallen down on the posterior cavity. So we are trying to hold it stamped up on a V-lance and forceps, trying to remove it through the keratoprosthesis. And you can see the capsule is still attached. Then we are cleaning the ciliary body, removing the fibrinous membrane to avoid hypotony and tesis long term. Then we are placing the graft tissue. So my final conclusion is that every effort should be made to preserve a patient eye. Both procedures in a single surgical time, optimizing maneuvers in the vitreous space. Glove salvage rate of near 38 has been reported in the literature using temporary keratoprosthesis for endophthalmitis. So the conclusion is in severe corneal haze with endophthalmitis involving the eye, surgery using temporary keratoprosthesis, vitrectomy, and then corneal graft may be tried.
I want to emphasize that not doing vitrectomy because the cornea is hazy is criminal. If you are able to have a TKP and you don't have a corneal button, you still have to go and do the TKP vitrectomy, and then you can leave the TKP device in and do the transplant a few days later. Okay. We had more than 50 cases of a vitrectomy with a TKP, and we have an over 90% graft retention without needing a second surgery.
Thank you very much.
If the cornea is not severely damaged, you can reuse that cornea temporarily if you do not have a cornea readily available.
Yes.
Can I just add two things, because I have the microphone and so I can talk. There are two things, with 2 points which I always think about, and I'm sorry, I want to communicate them to you. The question of concentration was brought up. What happens when I put silicone oil? What happens when I put gas? What happens? If you use antibiotics in the infusion continuously, the problem does not exist. Because in the end, whether you leave BSS, whether you put in gas, whether you put in silicone oil, the amount of BSS which is left with the antibiotics inside has the same concentration. The concentration has not changed. So you don't have to think about what concentration you're going to be using, because it's a stable amount which you've had throughout the surgery. So my recommendation is to use infusion, antibiotics in the infusion, plus all the other, I think, advantages that come from that. The advantage being where the vitrectomy probe goes, the infusion with the antibiotic follows. It's a wonderful way of getting the bacteria. Second, again, hyaloid, you don't have to remove totally. I don't know if you agree, Ferenc, or not, but you want to remove it from the macular area. So this technique, which I have called fenestration, you can call it whatever you want, just open up the posterior hyaloid over the macula, nothing else, up to the arcades. You get the pus away, and you get the antibiotic directly touching the retina where it really matters most, which is the macula. That's all I have to say. Any more questions, comments? If not, we go for the coffee break. Please.
How much you put in the irrigation solution of the antibiotic? So what is the concentration of the antibiotic within the irrigation solution?
This is something that I can't tell you, because the nurses generally do that. But it's just, you just multiply what the optimal, I think it's 500 milligrams of vancomycin in 500 cc's. They just multiply what you would inject for the volume of the bottle. So 500 milligrams, I think they put 500 milligrams in 500 cc's, but I'm not sure about that. You would have to work that out.
But you can look to the internet site. This recipe is now more than 10 years and did not change, and it gives you all the concentration for use intravitreally or in the infusion line. And you can calculate that approximately by 5, because the eye has 5 cc volume. That is the concentration that is left if you use it in the infusion line. And remember that the eye is soaked if you have been doing surgery with the infusion all the time.
I'm using clindamycin, gentamicin, and dexamethasone in the infusion fluid, which I learned from Dr. Payman years ago.
One suggestion to answer your question. The concentration should be, in my view, the same as the injection, because otherwise you have a very low dose. To avoid the expense of putting so much antibiotic, which is expensive, into the bottle, is to use a small bottle, 50, 100 milliliters, which is good for most of your surgery, and then you don't throw away a lot of antibiotics.
Thank you.
Yeah. I have the microphone now. I've been waiting for the end of the session to hear about certain topics which I have not heard. So I really have to attract the attention to those topics. I've been seeing a lot of bleb-related endophthalmitis, which I believe they are a special group of patients, because these patients have had surgery years ago and they come, unfortunately, they are diagnosed late. Although they have all the symptoms, they have pain, they are complaining, and all you have to do is actually just pull the lid up to see the bleb. And they go on and on until they go into an endophthalmitis. So please have this in mind, because the treatment is so easy. Just inject the bleb with antibiotics. It will solve the problem. This is the first. The chronic endophthalmitis, again, these have had cataract surgeries, maybe a month or 2 or 3, and then you get repeat inflammation, granulomatous uveitis. They go to the uveitis clinic. They go and come, and finally they are not diagnosed, and you get those patients later on. Although with the surgery they do well. So these are the second cases which have not been tackled during the discussion. The third, which I also had a couple of patients all in the last 2 weeks, are suture-related endophthalmitis. Again, if you leave a patient with an exposed suture, please, whenever you see an exposed suture or a loose suture, remove it, because I lost 2 eyes in the last 2 months because of that. It was simple, it was not done, and they had a very, very, very fulminant endophthalmitis despite repeat vitrectomies, and the eyes were lost. I just wanted to say that.
I think those are good points. Just to the blebs. You have not mentioned that all the surgery that now is done with tubes. Tube surgery is becoming more and more common with glaucoma. And those tubes, sooner or later, despite the fact that you put a scleral flap, those tubes sooner or later become eroded, very exposed, very thin conjunctiva. So you know those patients are going to have problems. So what I tell my patients, as husband and wife, I always say, when you put the drops in, always lift the lid and see. If it's red, come back. That is something you must keep in mind. Sutures, when you remove the sutures, please remember it is a surgical procedure. So you want to put povidone iodine inside the eye, the usual thing you would do for an injection, and then remove the suture. Otherwise, you're dragging whatever is in the conjunctiva into the eye itself. So two very important points. Thank you. Ron.
A quick comment regarding the concentration of antibiotic in the fluid that we use for vitrectomy. You know, there is a quick rule of thumb. So imagine the eye is 5 ml, the volume, and the bottle that we have normally is 500 ml. So whatever dose that we are going to use, which is for vancomycin, like 1 milligram for intravitreal injection, you multiply it by 100 times. Because the volume of that bottle is 100 times more than the volume of the eye. And then you get the same concentration dye. Very simple. Whatever dose you are normally using, multiply it by 100, put that in the bottle, whatever you are using for intravitreal injection.